How's it going, guys? We have a pass level question for TCK3. For saying for step 1, you got to ace 2CK eventually. 62-year-old dude has a transient ischemic attack. A TIA is a stroke lasting under 24 hours. It's ischemic because the non-contrast CT of the head, which we do looking for blood, is negative. Hypertension, dyslipidemia, smoking, his risk factors. ECG is normal. What are we going to do to evaluate the cause of the patient's symptoms? Choice A, brain MRI is wrong. It's not routinely done when evaluating for stroke. I've never seen as correct answer on NBME either. In theory, it can look at penumbric regions of the brain, which is a fancy word for ischemia, especially in patients who we don't know when they first had stroke findings. For example, the wake-up stroke, where a patient woke up 2 hours ago with stroke-like findings, but we don't know if they qualify for the TPA threshold. So ischemic stroke, you give TPA under 4.5 hours. If it's ischemic stroke over 4.5 hours, you give aspirin. Hemorrhagic stroke, you just manage the hemorrhage. So take them off / reverse anticoagulation, manage hypertension, etc. But patient woke up 2 hours ago. We don't know when their stroke began. Maybe it began 6 hours ago when they were asleep. Okay, so in theory, MRI can have a utility in that case, but for USMLE, it's the wrong fucking answer. In this case, wrong fucking answer. Choice B, carotid duplex ultrasound, correct answer. This is what's going to go down. If on USMLE, a patient has a stroke, TIA, retinal artery occlusion, and has hypertension, you're going to do carotid duplex ultrasound looking for a carotid plaque that's launched off to the brain / eye. If they have normal blood pressure, especially if they're older, such as over the age of 70, you're going to do a regular ECG. If that's normal, you're going to go on to do a 24-hour ambulatory ECG monitor, aka Holter monitor, to look for paroxysmal atrial fibrillation, where you have a left atrial mural thrombus that's launched off to the brain / eye. Okay, if they give you a patient where they don't mention blood pressure at all, they just say 65-year-old dude has a stroke, TIA, or retinal artery occlusion, they force you to choose one of these answers, it's going to be duplex ultrasound. If they give you a random 65-year-old dude, don't mention blood pressure at all, and they say there's random syncopal episodes, then it's going to be ambulatory ECG monitor. Okay, it's difficult stuff, it's confusing, but that's what the NBME wants. So hypertension is the biggest risk factor for stroke. It's the most common risk factor, and that's because you have the systolic impulse pounding the carotids, causing endothelial damage and atheromata development. Okay, so it's more important than smoking. That's high yield for TCK3. Obviously, the dude would have to quit smoking. Yes, it's important. But if they ask you what's more important for preventing stroke, the answer is blood pressure control over smoking cessation. Okay, so in the population, most people who get a stroke, it's because of hypertension. Now, where it gets tricky is if a patient happens to have atrial fibrillation and hypertension at the same time, the atrial fibrillation is the more important risk factor for the stroke, okay? But overall in the population, hypertension, more common and it eclipses smoking. So if you do the carotid duplex ultrasound, it's greater than 70% symptomatic, 80% asymptomatic, you do endarterectomy. If you're under those thresholds, you're going to do triple management of 1, antiplatelet therapy, aspirin is sufficient on USMLE, 2, ACE inhibitor or ARB, they really like lisinopril, and 3, statin. Okay, now if when we talk about the symptomatic, asymptomatic, TIA stroke, retinal artery occlusion is symptomatic. Asymptomatic could be a bruit, let's say. That's a sign, not a symptom, okay? So carotid angiography, never seen as a correct answer. Only wrong answer on USMLE. In theory, like you would do it if a patient were to go on to have surgery. So your first step is going to be the ultrasound to look for a degree of occlusion. You say, oh, he's got 90% occlusion on ultrasound, and we're going to do endarterectomy. Sure, prior to surgery, you would do carotid angiography in most cases to further understand the anatomy and what you're doing prior to the procedure, but it's not the best initial step. As I said, I haven't seen as a correct answer on NBME. Wrong fucking answer. Choice D, Holter monitor, wrong fucking answer, as I already harped on. You're going to do this when you're looking for paroxysmal atrial fibrillation. So stroke, TIA, retinal artery occlusion, or patient has normal blood pressure, especially if over 70. And if they don't mention the blood pressure, but a patient has syncopal episodes, because you want to see if the syncopal episodes coincide with paroxysmal atrial fibrillation episodes. Wrong fucking answer. Choice C, transthoracic echo is wrong. Now, if you do the Holter monitor and it turns out the patient does have paroxysmal atrial fibrillation, you can go on to do an echo to look for the left atrial mural thrombus. Okay, now sometimes the mural thrombi are not going to be seen on transthoracic echo. You got to do a transesophageal echo. It's when you want to look for things like vegetations and endocarditis or left atrial mural thrombi or things like myxoma. Transthoracic echo, well, that's why it's the wrong fucking answer. Okay, but transthoracic echo is classically for ejection fraction patients who have left heart failure, right? Wrong fucking answer. You know the deal. I'm 2 minute more content on social. Appreciate your time. That's it.